delighted to see so many students here. The talk is a very simple talk on the current management of IBD. This is not for the senior gastroenterologist sitting here, but I think the internists and students will probably like it. So IBD are two things, ulcerative colitis and Crohn's disease. So ulcerative colitis is a recurrent episode of inflammation affecting the mucosal layer of the colon. So it has got an implication. Crohn's otherwise is an inflammation of affecting any portion of GI tract, and it is transmural. So in Crohn's you will see more complications like stricture, like fistula, obstruction, etc., which is not that common in ulcerative colitis. So that's the background. And ulcerative colitis will involve only mainly the rectum and the colon. So I've divided my talk into 4 halves. Management of mild to moderate ulcerative colitis, which is quite a low risk. Moderate to severe UC. Mild Crohn's disease, again low risk, and management of severe Crohn's. So starting with management of mild to moderate UC, which are actually low risk patients. So how do we define mild disease? Usually the stool frequency is less than 4 stools a day. There's no systemic toxicity. The patients don't have any fever, any other symptoms. At endoscopic evaluation, the colonoscopic evaluation actually shows mild disease. Moderate, the stool frequency is of course more, around 4 to 6 times. Patients do often can notice blood. They can be mildly anemic, usually the hemoglobin is above 10. Mild systemic toxicity may be present, and endoscopy actually shows moderate disease. And the goals of our therapy for any IBD is achieve both clinical and endoscopic remission. So what about mild and moderate UC? So I've divided into different parts. So first is proctitis. For the students, the proctitis is inflammation only of the rectum. And for that, simple treatment like mesalazine or steroid suppository or enema might be useful. And you often need to give it for 4 to 6 weeks. You might start with a lower dose and then you increase the dose. But if the inflammation is a bit more, extending to the sigmoid, we call it proctosigmoiditis. So that's involved in the rectum and the sigmoid. Here also, you can use the suppository, but the enemas usually work better. And in these cases, often you need oral medication like mesalazine or sulfasalazine, and you might need to continue a maintenance treatment to keep the symptoms under control. However, if the colitis is left-sided or extensive, you will clearly need oral medication. The enemas don't work. And there will be a group of patients who will fail to respond. The first question to ask is whether they're taking the medication, because in non-compliance. However, there will be a group of patients who will have refractory disease and not responding to the 5-ASA agents. In those cases, steroids. As you all know, steroids are very useful. We usually start on a higher dose of 40, and obese patients might need to increase the dose to 60 also. And they're usually quite useful. For the students, actually, there's a new treatment. What we often use these days is budesonide MMX, which is a delayed and extended release medication. 9 milligrams a day, we can give it for 6 to 8 weeks, and it often helps quite well in left-sided, mild to moderate UC. So this is something for you to remember. What about moderate to severe UC? I've already mentioned moderate. Severe disease is actually patients having loose, bloody stool more than 6 times a day, anemia, hemoglobin dropping, systemic symptoms, fever, pain, and there are colonoscopic appearances which suggest severe disease. Also to remember, there will be a group of patients, as I mentioned, who often do not respond to glucocorticoids. So we divide into 3 halves: who are steroid responsive, who are steroid dependent. Steroid dependent means we cannot taper the dose of steroid below 10 milligrams a day, then they will get recurrence. Or steroid refractory, when there is no response to steroids after taking steroids for almost a month. So that's how we actually classify patients before starting treatment. With any moderate to severe colitis, or even with Crohn's, the first thing to do is the induction treatment. So first we have to control the disease. Again, great role of steroids. Unfortunately, you cannot continue steroids indefinitely because of long-term side effects. And here also comes the role of budesonide MMX, which I just mentioned. And nowadays, we are more and more using anti-tumor necrosis factor. You've probably heard of infliximab, adalimumab. I use infliximab quite more, three doses, 0 to 6 weeks, 5 milligram per kilo body weight. And it does work quite well. However, sometimes you don't use it alone, and there are evidence that if you use immunomodulators like azathioprine or methotrexate, the action is better. These are the new kids in the block. Ustekinumab, which is an anti-interleukin 23 antibody, and benralizumab, which are anti-integrin antibody. Now, we talk about these medications. Do remember, all of them do have side effects, especially with anti-TNF. You've got to rule out any evidence of TB before you start the medication. Keep in mind there can be activation of hepatitis B. Luckily, this new drug, ustekinumab and benralizumab, probably has got less risk in TB patients. So this is something new, which we have started using it, and we are finding it's quite useful. Now, patients who are not responding to this treatment, this is also a new armamentarium which has come to our, which we are using, is JAK inhibitors. So you have probably heard of tofacitinib and uvacitinib. Tofacitinib has been used for rheumatoid arthritis before, psoriatic arthritis before. We usually start a dose of 10 milligrams twice daily, and usually see a response within 4 weeks. Again, the caution is thromboembolic and cardiovascular disease. You need to be careful about these patients, and also often varicella vaccination is recommended. Surgery, I won't talk detail about it. However, there will be a group of patients who will need to have surgery. It's a big surgery. You need to get rid of the rectum and the colon, and probably will have anastomosis. I will skip this because I think we are running out of time. So, regarding moderate to severe UC, we have done the induction. How do we maintain the remission? Again, if the patient were on steroids, you often need to give immunomodulators like azathioprine or methotrexate, or continuum biologics. The problem is biologics are often difficult to use in India because of the cost. For anti-TNF, you can continue anti-TNF. Similarly, with the ustekinumab, you can continue it subcut every 8 weeks. For JAK inhibitors, the evidence is there for a year. Again, lower dose. We try to cut down from 10 milligrams twice daily to 5 milligrams twice daily. So that's how. So you have induced the patient and will need to maintain the treatment, and they often need lifelong treatment. New thing, fecal microbiota transplantation. You'll probably hear about this more and more. This is another talk actually, which I'm not going to make. One thing we often tend to forget is nutrition. All these patients will need adequate nutrition, and help of a dietitian will be of some benefit. Coming to Crohn's disease, as management of mild Crohn's disease is slightly different from UC, and choice of treatment will depend on where is the disease. As you know, Crohn's can affect anywhere from the mouth to the rectum. So where is the disease, how severe the disease is, and again, how do you do the induction and continue the remission. Medical therapies are very similar: 5-ASA, steroids, immunomodulators, and biologics. So if you go to the mild Crohn's disease, I very briefly touch how do we assess mild Crohn's disease. There are two things: Crohn's disease activity index and Harvey-Bradshaw index. So this is quite often used. You can use your app and do a CDI score quite easily. There are multiple factors, and what we see is that the CDI is around 150 to 220. It's a mild disease. More than 450 is severe. In between is moderate, and you can assess it by doing the score, but mainly it's the weight loss and the systemic symptoms which often affect it. For management of mild Crohn's disease, you will know that the main site that Crohn's often affects is the ileum or proximal colon. And again, budesonide is the drug of choice, which we use for 3 months and is often very useful. If budesonide doesn't work, we go to the immunomodulators like azathioprine. Of course, prednisone is an option. There is some debate about 5-ASA, whether it's as useful as budesonide, we do not know, probably not. It's probably, however, better than placebo. So I will probably use budesonide first in case of terminal ileal disease. What about diffuse colitis or left chronic involvement? In mild Crohn's, again, often we have to give steroids and maintain it with 5-ASA or sulfasalazine. Now coming to the moderate and severe Crohn's disease, again, as I mentioned, you have to select the induction therapy, and as before, Anti-TNF agents and immunomodulators or anti-IL-2, 12 and 23 and anti-integrin are quite useful. Here for our Indian context, I will also mention biosimilars. This is very useful for us. What is a biosimilar? It's a copy which is similar but not identical to the original product. But however, it's much cheaper than the original product. So often we do use biosimilars. Very briefly, as I was mentioning, in Crohn's you will see fistulating disease, and in those cases, infliximab along with azathioprine has been quite a drug of choice for most of us. Again, for induction treatments, steroids are often very useful. However, we need to start another immunomodulators or another anti-TNF to give long-term treatment, but you cannot continue steroids indefinitely. I keep repeating, but nutrition and even parenteral nutrition often required in severe Crohn's disease. And this is also quite important with ill patients. There will be patients when you can't give all these drugs, especially if the patient turns into small bowel obstruction or localized peritonitis or abscess. You might need the help of our surgeons or radiologists to drain the abscesses or for the obstruction. And once those things are done, then you can think about stronger agents like anti-TNF or steroids. Antibiotics has got a huge role in this. Do not forget to start antibiotics, but do keep in mind about the nutrition. And how do we maintain? Very similar to UC, anti-TNF agents and immunomodulators combination work quite well. If the patients are well controlled, we usually try to switch to only one medication, and they need to continue long term, because if you stop this medication, the relapse rate can be as high as 50%. And patients who lose response to TNF, we switch. We go from one agent to the other, or increase the dose depending on that. Again, thiopurines, azathioprine and methotrexate are often required. So I'm coming to my last slide. Sorry, I had to rush a bit because of the time. As you all realize, IBD can be very difficult to manage. It's very important to initially define the disease activity, severity and extent. You always start with the induction agent, and once the patient is well controlled, you think about maintenance therapy. We have got multiple drug options, but our aim is both for clinical and endoscopic remission. Do not forget about nutrition. Do not forget about multidisciplinary approach, because you will need the help of dietitians, radiologists, and the surgeons to treat them. Thank you very much.